In this lecture, the first on a series about the upper limb, we're going to look at the surface anatomy and osteology of the entire upper limb. So we're going to look at the surface anatomy of the shoulder, the arm, the forearm and the hand, all of these regions making up the upper limb. And then we're going to move on to the osteology. We'll look at the clavicle, the scapula, the humerus, ulna, radius, the carpal bones, the metacarpals, and the phalanges. And in each of these bony structures, we'll look at specific landmarks, and these are important for muscle attachments. We'll then finish by looking at the various movements that are performed by the upper limb, which is a complex part of the appendicular skeleton, enabling a great range of movements. So if we just look at the general arrangement of the upper limb, then on this slide we can see we have a nice body plan of both the male here and the female. And on the male we can see indicated we've got the upper limb. Specifically we've got the arm region here, which is connected to the trunk by way of the shoulder, which we'll talk more about here. And then connecting the arm to the forearm, we have the elbow joint, which we can see here. And then most distally, furthest away from the main core of the body, we find we have the hand. The hand, remember, connected to the forearm via the wrist joint. On this picture here, we can see an anterior view of the upper limb, and we can see more features, more surface features. We can see we have this shoulder region, and we can see a region known as the axilla. This is your armpit. And we can see we have the deltoid, this muscular region that covers the shoulder joint. And we'll look at the deltoid muscle in quite some detail as that covers the shoulder joint. We then pass down distally towards the elbow, and between the elbow and the shoulder, we find we have the arm. We can see a groove here that is separating biceps brachii and triceps brachii here. And this we can see a nice little cleft is where you can palpate the brachial artery. So there's some important surface landmarks here. We can then move on to the elbow joint, and we have a prominent bulge on the medial aspect of the elbow joint. This is known as the medial epicondyle, and that's important because the ulnar nerve runs alongside this structure, and we'll cover these details throughout this lecture series. We then pass distally from the elbow joint and we see the forearm. We can see the anterior region of the forearm. We have a prominent bulge on the lateral surface of the forearm, and this is due to a really important muscle known as brachioradialis. So we can see a bulge here caused by brachioradialis. We can then move distally again, and we can see the hand. The hand is connected to the forearm via the wrist joint, where the phalanges, where the carpal bones connect to the radius and the ulna to form this wrist joint. And we can see we have the palm of the hand, and then we can see we have the thumb, the index finger, the middle, the ring and the little finger that make up the digits of the hand. So these are some key surface landmarks we can see on the anterior aspect of the upper limb. If we look at the posterior aspect, then again we can see we have this muscular region here caused by the mass of deltoid muscle. And then we can see the posterior region. We can see some impressions for the various heads of triceps muscle. Again, we can see the medial epicondyle, this time from the posterior view, just as we saw it on the anterior view here. We can see the olecranon, this bony prominence on the posterior surface of the elbow. Once again, if we move into the forearm, we can see we have this posterior aspect here, and again on the medial aspect, so running along the same aspect as the thumb, this medial aspect here, we can see we have brachioradialis. If we pass to the hand, once again, we can see the thumb, index, middle, ring, and little fingers again that make up the digits, and we can see this dorsum of the hand. Remember that forearm is connected to the hand via the wrist joint, and we have two what are known as styloid processes of the radius and the ulna, and we'll look at these in detail when we look at the osteology. But both these styloid processes of the radius and the ulna, the radius being lateral, the ulna being medial, then we can see these bony prominences, and these can be palpated at the wrist joint. So this region that we can see here on the slide is part of the superior appendicular skeleton, and it forms the upper limb. The upper limb is important because it has a high level of mobility, which is given to it via the pectoral girdle, which we'll see in a few slides' time. It's also characterized by its ability to grasp structures. The hand is a really important structure at the distal end of the upper limb, and its ability to manipulate the fingers to hold, to grasp structures. So when you're holding a pencil to write, it's a complex arrangement of movements that allow your fingers to assume this position. It's a key difference from the lower limb. The lower limb doesn't have as much mobility as the upper limb, and also it doesn't have as much function of the feet compared to the hand. So it's a lot easier to pick up structures with your hands than it is with your feet. However, the main benefit of the upper limb, being its mobility, isn't the same as the lower limb because it doesn't need to be as mobile. And the lower limb is important for stability. So you don't have a greater range of movement, but it's important in being able to make sure your posture is correct, being able to support the entire weight of your trunk. So there's a battle between the upper limb and the lower limb. The upper limb increasing mobility, but it's got a high level of instability. So it's more prone to having dislocated shoulder joints. There's a whole series of specialized joints in the upper limb. I mentioned one of them, the shoulder joint, and we'll see that in this lecture series. But the elbow joint and various joints most distally are very specialized, allowing for this increased range of movement. As I mentioned also, the axial skeleton is connected to this appendicular skeleton via the pectoral girdle. And we can see that in the next few slides. We can see here we have the axial skeleton. So this axial skeleton down here constitutes your vertebral column. We can see radiating from your vertebral column, we have the ribs, and these all form part of your axial skeleton. Attaching to the axial skeleton for the upper limb is the clavicle. And the clavicle forms part of the appendicular skeleton. The appendicular skeleton, the upper limb in this case, the superior appendicular skeleton, is connected to the axial skeleton by way of just one joint. This joint that exists between the medial end of the clavicle and the sternum, the sternoclavicular joint. This is the only joint that allows the superior appendicular skeleton to articulate with the axial skeleton. And this small joint enables a high range of movement. So the superior appendicular skeleton, the upper limb, therefore has this wide range of movement. So if we look at this appendicular skeleton in more detail, this is the superior appendicular skeleton, the upper limb. The lower limb would be your inferior appendicular skeleton. And we can see, I've mentioned these before, it includes a whole series of bones. We've got the clavicle, which we can see here. The clavicle, this medial end of the clavicle attaching to the sternum. And then we have the scapula, which you can see here, this flat triangular shaped bone that lies alongside the posterior aspect of the ribs. We can then see we've got this long bone here, which is the humerus. The humerus is articulating with the glenoid cavity of the scapula, forming the glenohumeral or the shoulder joint. And then we have this long humerus that articulates with both the radius and the ulna to form the elbow joint. We can then see we have two long bones in the forearm, the radius and the ulna, the radius being lateral to the ulna is medial. And we can see that the radius and the ulna articulate with the carpal bones at the wrist. And you can see we will discuss the various radiocarpal joints in later lectures. Here we can see a cluster of these 8 carpal bones, and these constitute the wrist joint. They articulate with a series of long bones here, which are known as the metacarpals. And the metacarpals allow for articulation with some small bones here called phalanges. And these form the joints of your fingers or the joints in your hands. And they have a number of these. We can see in fingers 2, 3, 4, and 5, we have 3 phalanges. And in digit 1, the thumb, we have 2. And this allows us to manipulate objects so we can move our fingers into various different positions due to these high number of phalanges within the fingers. So let's have a look at these bones in a little bit more detail. Let's start off by looking at the clavicle. And on the screen, we can see both a superior and an inferior view of the clavicle. We can see here we've got the sternal end, here we've got the sternal end, and this is what articulates with the sternum. And then we can see we've got the acromial end over here as well. And these form articulations with the acromion of the scapula. So let's look at this in a bit more detail. As I've said, the clavicle connects the sternum to the scapula. It's important as it keeps the upper limb away from the trunk. So it moves the upper limb away from the trunk, again allowing an increased movement. So there's less chance for the upper limb to hit the chest wall. It's been moved away from the trunk, increasing the movement. We can see here we've got the superior view of a right clavicle, as if we're looking down onto it. We can see again this sternal end. We can see this acromial end. This medial half has a curve, and this lateral half has a curve as well. And it's important in being able to recognize a left from a right clavicle, and also the superior and inferior surfaces of the clavicle. So superiorly, a clavicle is smooth. So here we can see on this superior view, this smooth shaft of the clavicle. There's no undulations, there's no grooves, which we'll later see on the inferior view. So if you're seeing a smooth surface, you're looking at the superior surface of the clavicle. If you then see one of these curves, and along its anterior surface, which is here, it's got this curve. This curve is convex. So anteriorly, this curve is convex. Whereas more laterally over here, we can see anteriorly, the curve is concave. And this is how we can orientate our clavicles. We find the smooth superior view, and then anteriorly we have a convex curve, and anteriorly here we have a concave curve. And obviously this is going to be the opposite along this posterior surface. If we then move towards the inferior surface, so this is if we're standing underneath the clavicle and we're looking up, we can see that it's roughened. There's a whole series of tubercles, of features, which are important for articulation with ligaments. And here we can name a few of them. We have what's known as the conoid tubercle. We've got this tubercle here. This is by the acromial end, and we've got the conoid tubercle. This is part of the coracoclavicular ligament, which we'll talk about in more detail later on, an important stabilizing ligament of the shoulder. And we also have, connecting really the conoid tubercle to this acromial end, the trapezoid line. We can see the trapezoid line, this slight roughened area here. And that's also important because that's where the trapezoid ligament attaches. And this again is part of the coracoclavicular ligament. And this is important, again, in helping to stabilize the shoulder joint. We can see we have an impression for the costoclavicular ligament. We can see that here. This is by the sternal end of the clavicle, and as its name suggests, the costoclavicular ligament is going to attach to the ribs, and this is important in the sternoclavicular joint, which we'll look at again later on in this series. We also have a subclavian groove, and we can see a subclavian groove here, and this is important for attachment of subclavius muscle, a small muscle that runs on the underside of the clavicle, and we'll cover that when we look at the musculature. Another feature on this inferior view of the clavicle is this nutrient foramen, and that is where the nutrient artery passes into the clavicle to give it its blood supply. So here we have an overview on this slide of the clavicle. This is a right clavicle in this diagram. We have the smooth superior surface, which is convex anteriorly for the medial half and concave anteriorly for the lateral half. The inferior view has a number of features. It's roughened, I've got the conoid tubercle, the trapezoid line, the costoclavicular ligament impression, and also a groove for subclavius. If we now move on to the scapula is connected to the sternum by way of the clavicle. And we can see here we have numerous views of our scapula. Here we've got a posterior view. Here we've got a lateral view, the middle picture on this slide. And here we can see we've got an anterior view. We can see here on this side of the screen. So let's look at some features of the clavicle. As I mentioned, it's a triangular, it's a flat bone, and it sits on the posterolateral aspect of the thorax at the level of ribs 2 to 7. So it sits directly posterior to the rib cage at the level ribs 2 to 7. The posterior surface, which we can see here, is divided by this prominent ridge. This is known as the spine of the scapula. We can see it dilates into this large structure here, known as the acromion. But the spine separates the posterior surface of the scapula into a supraspinous, so supraspinous, above the spine, and infraspinous fossa. We have a supraspinous and infraspinous fossa. And these fossae are important in offering muscle attachments that work on the shoulder joint. And again, we'll look at these in more detail. So the posterior surface has this prominent spine, this ridge, forming a supraspinous and infraspinous fossa. On the anterior surface, it's quite featureless really, but we just have a fossa again for subscapularis muscle, and this fossa is known as the subscapular fossa, which we can see here on this anterior surface. So the subscapularis muscle, which we will cover in a few lectures' time, is sitting directly between the ribs and the scapula. So, some more features. We have what are known as angles on the scapula. We have 3 angles. We have a superior, an inferior, and a lateral angle. So let's just orientate ourselves. This is at the top on the posterior view, so we have our superior angle. The superior angle is connected to this inferior angle via this medial border. We can see this medial border of the scapula here. We've got a superior angle, this tip, and we've got an inferior angle here. And these two are connected by way of this medial border. We also have a lateral angle here, and that forms the 3 points of this triangle-shaped scapula. The superior angle is connected to the lateral angle by way of this superior border, and the lateral angle is connected to the inferior angle by way of this lateral border. So on the scapula, we have these 3 angles, superior, inferior, and lateral, and these are connected via borders, medial, lateral, and superior borders. And we can see these on the screen. Superior angle, inferior angle, lateral angle. Medial border, lateral border, superior border. And let's have a look at a few more features that we can see. First of all, on this lateral border, we can see here, we have a neck of the scapula. So this narrowing where the superior border and the lateral border begin to converge, we have a neck, and then we have a head, the head of the scapula. And this is characterized by a depression, which is known as the glenoid cavity. And that is going to articulate with the head of the humerus, forming the shoulder joint or the glenohumeral joint. So we can see we've got the glenoid cavity here, forming the head really, and just medial to it, we have the neck of the scapula along this lateral border. The superior border here, we have an important feature, and this is known as the suprascapular notch. The suprascapular notch is important as it allows a blood vessel to pass through or over the top of the scapula, and we'll come to that in due course in some later lectures. So here we can see various features which we can see on this posterior view. We can see if we look at the anterior view, we can again see we've got this neck of the scapula and we've got a head of the scapula forming the glenoid cavity, and we can see the suprascapular notch. If we look at the spine, so let's just concentrate on the spine of the scapula, then we can see it starting medially from this medial border, and as it travels laterally, it actually gets bigger and bigger until it forms this dilated bulge, which is known as the acromion. And we can see this here on the posterior view. We can see it's prominently passing more laterally than the actual main body of the scapula, and we can see the acromion here on this anterior view. And here on this lateral view, which is if you're looking from the lateral aspect, we can see we've got this costal surface. So this is the anterior surface here that's sitting against the ribs, and this is the posterior surface here, so we'd have skin along here. Here we can see the glenoid cavity, and then radiating up here, we've got the acromion. We can see it's almost running completely over the glenoid cavity, and that's important, as we'll come to realize, because it can help to prevent superior dislocation of the humerus. So we've got the acromion, and remember in a few slides previously, we had the clavicular acromial ligament, where attaches a ligament attaching from the acromion to the clavicle, and we'll come back to that. So we've got the spine here of the scapula, and it articulates with the clavicle. If we look at the head in a bit more detail, then we've got the glenoid cavity. We can also see, if we look clearly here at this lateral view, here's the glenoid cavity. We can see we've got a supraglenoid and an infraglenoid tubercle. So small little elevations, little bony masses on the superior and inferior aspect of the glenoid cavity. And these are important for muscle attachments, as we'll see. Both long head of biceps and triceps attached to the superior and infraglenoid tubercles, respectively. So here we've got the glenoid cavity and the supra and infraglenoid tubercles. We'll come back to these later on. The final feature I want to talk about is the coracoid process here, and this is an important kind of bulge again coming up from the superior border and from the head of the scapula, and this is the coracoid process. Again, it helps to form muscle attachments. We'll talk about coracobrachialis in a few slides' time, and we can see here the coracoid process. Here again on the lateral view we can see coracoid process, and here on this anterior view we can see again the coracoid process. So some important features here on the scapula. Now let's move to the humerus, this long bone that sits within the arm of the upper limb. It attaches proximally via the head of the humerus to the scapula and articulates distally at the elbow joints with the ulna and the radius. So here we can see both an anterior and a posterior view on the slide. Let's look at this in more detail. So this is the anterior view of a right humerus. So here we've got the head of the humerus that will be articulating with the glenoid cavity. So the scapula will be positioned here. And this is the lateral aspect of the humerus. And we can see down here we have a structure called the lateral epicondyle. We'll come back to that later on. I just really want to concentrate on this proximal region of the humerus, up here towards the head of the humerus. And we can see that we've got this head here that's going to articulate within the glenoid cavity to form the glenohumeral joint. And you'll see that the glenohumeral joint is a really mobile joint. We'll come back to this when we look at the joint itself and the ligaments that help to hold it in more detail later on. But we can see that the glenoid cavity is very shallow. It's not a cup-like, which has the head sitting into it. The glenoid cavity is very shallow, and the head of the humerus sits alongside it. And due to this shallow glenoid cavity, the upper limb is very mobile, so we can all move our arm way above our head. And that owes that movement owes itself to the articulation between the head of the humerus and the glenoid cavity. The humerus has a neck. In fact, it has two necks. One neck is known as the anatomical neck, and the anatomical neck sits just behind the head of the humerus. It's an important attachment site for the joint capsule of the glenohumeral joint. We can see the head here, and then this dotted line is indicating the anatomical neck. The anatomical neck is positioned between these two important bulges of bone. These are known as tubercles. And the tubercles sit distal to the anatomical neck. So the anatomical neck is positioned between the head and these two tubercles. The second neck I want to talk about is the surgical neck, and that runs around the humerus below or inferior to these two tubercles. Let's concentrate on the tubercles for a moment. We have the greater and the lesser tubercles, and these are important in offering sites for muscles to attach. So importantly, the rotator cuff muscles attach to the greater and the lesser tubercles, and these are separated. These two tubercles are separated by a groove which we can see here, and this is known as the intertubercular sulcus or the intertubercular groove, and it runs between the two tubercles. And later on we'll appreciate that various muscles attach in this groove or this sulcus, and it also contains the tendon of the long head of biceps brachii that runs up in this direction here. We'll come back to that later on. Now let's move down on this anterior surface to the shaft of the humerus. We can continue down here with the lesser tubercle as the crest of the lesser tubercle, and another crest coming down from the greater tubercle here. And we can see this in more detail if we look at specifically the shaft of the humerus. We have these two crests coming from the greater and lesser tubercle, still forming this intertubercular sulcus down onto the shaft of the humerus. And we can see that on this more distal aspect of the humerus, we can see that as it tapers away, moves distally towards the elbow joint, we have what are known as medial and lateral supracondylar ridges. These medial and lateral supracondylar ridges are ridges formed as the humerus begins to dilate distally. So as the humerus passes towards the elbow joint, it begins to dilate. And these ridges are forming that dilation, which eventually leads on to the lateral and medial epicondyles. So we can see the medial and the lateral supracondylar ridges here. We can also see we have on the lateral aspect, again, we've got the head here, so this is the medial aspect. On the lateral aspect, we have a groove here, and that is known as the deltoid tuberosity. And that's the attachment site for the deltoid muscle. So deltoid muscle attaches to the deltoid tuberosity we can see here. Most distally, the humerus dilates into two condyles of the humerus. And these form the articular surfaces that articulate with the radius and the ulna. And these articulations form the elbow joint. There's two articular surfaces. We have the trochlea, we can see here, medially, and we have the capitulum laterally. And these are important for articulating with the radius. So the radius is going to articulate with the capitulum, and the ulna is going to articulate with the trochlea of the humerus. So these form two important articulation sites. We can also see just before these condyles, we have these little depressions called the radial fossa and the coronoid fossa. And these little depressions allow these radius and ulnar bones to sit in these little depressions when we fully flex our elbow. So they can accommodate, as we'll see when we cover the elbow joint, they can cover bony structures on the ulna and the radius. We will come back to them. If we look at the posterior view of the humerus, then there's not as much detail here. Once again, we can see this is a right humerus. We're now looking at the posterior surface. So here again is the medial aspect, and here we can see we've got the lateral aspect. The head of the humerus pointing medially to articulate with the glenoid cavity. We can just see now the greater tubercle. We can't see the lesser tubercle. That's more on the anterior aspect. And we can't see the intertubercular sulcus. But we can make out the position of the anatomical neck between the head of the humerus and the greater tubercle. And distal to the greater tubercle, we can see the surgical neck. We'll come back to the surgical neck because it has some important structures running around it. And therefore, fracture of the surgical neck can lead to some important functional deficits. An important structure that we can see on this posterior aspect is the radial groove that's passing down this posterior surface. We can see the radial groove. And the radial groove is important. It allows the radial nerve and the profunda brachii artery to run alongside it as they supply the posterior compartment of the arm. So we can see the radial groove here is on the shaft of the humerus, on its posterior aspect. We can also again see the medial supracondylar ridge. We can see the lateral supracondylar ridge. And they're giving rise to the medial epicondyle and the lateral epicondyle we can see here. So the radial groove, medial and lateral supracondylar ridges giving way to the medial epicondyle and the lateral epicondyle. Same features we can see on the anterior surface. If we look at the posterior surface of the distal humerus, we can then see that we have the olecranon fossa, and this is an important shallow depression for the olecranon, which is a bony structure on the ulna. And we'll look at that next as we look at the ulna. So this is the ulnar bone, which we can see in isolation. It sits within the forearm alongside the radius. And we can see we have a number of views here that reveal various bony landmarks. So let's have a look. The ulna is longer than the radius, and within the forearm it is involved in stabilizing the forearm, and of the two bones it's positioned medially. So the ulna is medial and the radius is lateral. Here we can see the anterior view, here we can see a posterior view, and this view is if we're looking at it from the radius. So as if we're looking at it from the radius's position. We can see it's really a lateral view as if we were the radius. And we've got some features which I'd like to detail. So proximally up here, we have the olecranon. We can see that here on the posterior surface, and here on this lateral view, we can see the olecranon. And that proximal kind of extension of the ulna helps to form this C-shaped cavity. And this C-shaped cavity is known as the trochlear notch. We can see we've got the trochlear notch here. We can see we've got the olecranon, this C-shaped notch, which gives rise to this coronoid process. Now, if you remember, on the anterior surface of the humerus, we had the coracoid fossa. The coronoid fossa. Well, this enables the coracoid process, to sit in it when the forearm is fully flexed. So we can see the coronoid process here, when the forearm is fully flexed, so the forearm is sitting against the arm, the coronoid process can sit inside the coronoid fossa, and that adds stability to the flexed forearm. So we've got the olecranon, which we can see, we've got this C-shaped trochlear notch, and we've got this coronoid process. The trochlear notch is going to articulate with the humerus. Okay? Specifically the trochlea of the humerus. So we've got this kind of barrel-shaped trochlea of the humerus, and that is going to allow articulation with the trochlear notch. We can also see the coronoid process. We can see it here on the anterior process. We can see it here posteriorly sticking out somewhat. Laterally, we can see we have the radial notch. We've got the radial notch here on this anterior view, and we've got the radial notch here on this lateral view. And that's important because that's going to receive the head of the radius. We also have this crest running down here known as the supinator crest, and that offers the attachment of supinator muscle. More inferiorly from the coronoid process, we find we have the tuberosity of the ulna, and we'll come back to that in a moment. So some important bony landmarks we can see on this proximal region of the ulna. If we look at the shaft of the ulna, then there's not a great deal to really mention, just that it has a sharp interosseous border. So here we've got the anterior view, we've got this anterior surface running down here, and we can see we've got this sharp interosseous border. We can see it quite prominently here on this lateral view. The interosseous border is important because it allows the interosseous membrane to run between the radius and the ulna. Distally, if we look at the ulna, we have the head, a rounded head, and then we have the ulnar styloid process. And this sticks out, we can see here on the posterior surface, we can see it here, and on this anterior view, we can see the ulnar styloid process sticking out. And this can be palpated medially at the wrist joint. The distal end of the ulna does not articulate directly with the carpal bones. There is an articulation there, but it's separated by an articular disc, and we'll come back to that when we look at the joints. So now let's look at the radius. This is a bone that lies on the lateral aspect of the forearm, and again we've got anterior, posterior, and a medial or an ulnar view, which we can see on this in this picture here on the slide. The radius is shorter than the ulna, and it's positioned more laterally. Proximally, we've got some details I'd like to talk about. We've got the head of the radius, and that is going to articulate with the capitulum of the humerus. But importantly, the head also articulates with the radial notch of the ulna. And these two bony features, articulations with the capitulum, articulations with the radial notch, allow a complex arrangement of movement. So we can see we have flexion of the elbow joint, and we also have the ability to supinate and pronate, where we turn the forearm over. The two bones of the forearm can turn over. And that's supination and pronation. We'll talk about that later on. But this is allowed to happen because of the bony features we can see on the radius. So the head of the radius here is going to articulate with the capitulum of the humerus, and then the head of the radius also articulates with the radial notch of the ulna. So we can see the head here, we can see the head on this posterior view, and also on this medial or the ulnar view of the radius. The shaft, again, has got this sharp interosseous border, just like the ulna did, allowing the interosseous membrane to articulate, and the shaft of the radius is going to widen quite distally as it passes towards the elbow joint. And again, we have a radial styloid process that can be palpated on the lateral aspect of the radius. If we have a few more details looking at this distal end of the radius, then we can see we have an ulnar notch, we can see here, and this allows articulation with the head of the ulna. We can see this clearly on the medial view, which is the ulnar view, so we can see that clearly here. We've got the ulnar notch allowing articulation with the head of the ulna. As I've mentioned, we've got the radial styloid process, and we've also got the radial styloid notch as well, most laterally within the radial. We also have what's known as a dorsal tubercle, and this dorsal tubercle is important as it acts as a pulley for the extensor muscles of the thumb, and we'll cover this in more detail when we look at the extensor muscles within the forearm. And this, important to remember, this dorsal tubercle on this posterior surface of the radius, allowing various muscles to attack the joint at a slightly different angle. So here we can see a whole series of bony landmarks on the radius. Okay, if we now move into the hand, then we can see we have a whole series of bones which are forming the wrist joint here. These are known as carpal bones. We can see on the picture. We then have 5 metacarpals we can see running down in this direction. And then we can see we have our phalanges that give rise to our digits. So let's just look at the carpals first of all. And there are 8 carpal bones. And these 8 carpal bones form 2 rows. with each row having 4 carpal bones in them. And this arrangement, this high number of bones, allows greater flexibility. So there's a high level of flexibility within the wrist joint, again allowing great movement of the wrist to assume numerous positions. We have the proximal row, and from lateral to medial. So here we've got the anterior view of the right hand, the anterior view of the right hand. So this is going to be lateral. We can see here the first digit, the thumb. This is lateral, and this 5th digit is medial here. And this proximal row, from lateral to medial, we have these 4 bones. We have the scaphoid, we have the lunate, we have the triquetrum, and we have the pisiform bone. And we can see these here. We can see we've got the scaphoid, we can see we have the lunate, we can see we have the triquetrum, and then we can see we have the pisiform. So 1, 2, 3, 4. These 4 bones that form this proximal row. We can see this on this anterior view, and we can also see them on this posterior view. Again, remember the thumb here is lateral. So from lateral to medial, we have scaphoid, we have lunate, we have triquetrum, and we have pisiform. These 4 bones that make up the proximal row. We also have a distal row, and these are formed by trapezium, trapezoid, capitate, and hamate. And these are a distal row. And again, we can see them from lateral to medial. We can see the trapezium, we can see the trapezoid, we can see the capitate, and then we can see the hamate, with the hook of the hamate as a prominent feature. We can see this on the anterior aspect, trapezium, trapezoid, we can see the capitate, and then we can see the hamate bone. So we've got these proximal row, and then we've got this distal row. We have these 2 rows with 4 bones forming each row. And we can see them both from the anterior and the posterior view. Here in the posterior view, we can see trapezium, trapezoid, capitate, and hamate. And these bones, these 8 carpal bones, offer great flexibility. Okay, if we look at the palm of the hand, this is known as the metacarpus. It's formed by 5 metacarpals, and these metacarpals all have a similar feature. There's 5 of them. They have a base. We can see a base here, 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 and here. And the base of the metacarpals articulates with the distal row of the carpal bones. So these 5 metacarpals, their bases articulate with the trapezium, the trapezoid, the capitate, and the hamate, with the proximal row of carpal bones articulating with the radius at the wrist joint. We have a nice shaft here, which we can see, and then we have a head. And the head of the metacarpals form the knuckles, which you can see on your own hand. And these articulate with the proximal phalanges of the digits. So a metacarpals, each individual metacarpal will have a base, a shaft, and a head. The head articulates with the proximal phalanges. And let's look at these phalanges. For digits 2, 3, 4, and 5, there are 3 phalanges. So digits 2, 3, 4, and 5, we have 3 phalanges. We have a proximal, we have a middle, and we have a distal. And each one of these phalanges, again, just like a metacarpal, is going to have a base, is going to have a shaft, and is going to have a head. Now, digits 2, 3, 4, and 5 have 3 phalanges. Digit 1 only has 2. It just has a proximal and a distal. So there we have the various bony features that make up the hand, the carpals, the metacarpals, and the phalanges. And to finish, I just want to talk about the various movements that is allowed to occur at the upper limb. And here we can see we have various movements occurring at the various joints. So here we've got the sternoclavicular joint, which allows a whole wide range of movements. Here we can see we've got its ability to elevate and depress the upper limb. So we have elevation, we have depression. We also have this movement known as protraction and retraction, where the upper limb is allowed to move forwards and then it's allowed to move backwards. And these movements occur at the sternoclavicular joint. We also, if we have a look here, have what's known as abduction and adduction. Abduction is when the upper limb is moved outwards, so it's moved in this direction. We've got abduction, and then when the upper limb is brought back to the trunk, we have adduction, where the upper limb is then returned to sit alongside the trunk. We have flexion and extension, so we have flexion of the upper limb, where we can see the upper limb is going to move in this direction, and then we can have extension, where the upper limb can move backwards in this direction. So flexion of the upper limb at the elbow joint, and then extension of the upper limb at the elbow joint. We also have what's known as internal or medial rotation and external or lateral rotation. Internal or medial rotation, we can see, is where the upper limb here again at the glenohumeral joint is going to move in this direction. And then external rotation is when it's going to move outwards. And we can see the limits that are allowed to occur, the movements, the limit to the movements here. We can see external rotation, we can see internal rotation, these important movements. I've just got a picture of a scapula here because this shows nicely the upward and downward rotation. If we've got an upward rotation of the scapula, then the scapular head here, the glenoid cavity, is going to move in this direction, and that's going to have the effect of pushing the inferior angle outwards like this. So as the glenoid cavity moves up like this, enabling our upper limb to move upwards, is if we're trying to, your right upper limb is trying to scratch your left shoulder, then your glenoid cavity is going to move up like this, and this means the inferior angle will move down. We also have downward rotation, where if you're trying to scratch your back, then the glenoid cavity is going to be depressed. We have this downward rotation, and the inferior angle is going to move outwards in this direction. If we look at the forearm and movements that are occurring in the elbow joint and at the wrist, again, at the elbow joint here, we can see we're going to have flexion and we're going to have extension. We can see here we have supination and pronation, where the forearm here in this what's known as this mid-pronate position is going to supinate, so your palm would be facing upwards, or pronating when your palm will be facing downwards. You can have abduction and adduction of your fingers. This is an important movement where your fingers can open up and they can close, so they can open up like this as we have abduction, or they can come together as adduction. And this is all about a central axial line, which we can see running here. So you can see that if this finger remains static, then we have adduction, but we can also have abduction. And because this axial line is running in this direction, you can see that it's possible for this middle finger to abduct this way and also to abduct that way. Adduction is when all the fingers are returned to this axial line running down here in line with the middle finger. Here we can see just simple flexion and extension of the wrist. So we can see extension where the wrist is going upwards, and we can see here flexion of the wrist when it is going downwards. We can also see that we have flexion and extension of the digits occurring at the metacarpophalangeal joints and the metacarpal joints, and we can have flexion and extension of those digits as well. So a whole range of movements characterized, which gives the upper limb its characteristic high level of mobility. And this is created by a whole series of muscles. And these muscles, which we'll talk about in later lectures, are attached to those bony landmarks that I've described. So we started off by looking at the surface anatomy, looked at the various regions, and then we looked at the various bony landmarks of the upper limb. So the clavicle, the scapula, the humerus, the ulna, the radius, the carpals, the metacarpals, and the phalanges. And then we finished by looking at the various movements of the upper limb.